So I have no disclosure related to this presentation, except this presentation focused on patient selection that leads to do nothing. And as interventionists, we rarely do nothing. So I would like to start with this. When Alice ventured through the looking glass in a well-known novel, Alice's Adventures in Wonderland, she encountered a fantastic world of celebrated characters, concluding with the poem, "Life, what is it but a dream?" It was a real dream to have help to a good number of patients who had no help before 2002. First case of Tavr was done by Alain Crebier, then followed by like a tsunami of cases and procedures throughout the world. More than 200,000 procedures done so far in more than 65 countries. In Saudi Arabia alone, almost 40% of our cardiac centers, they have active Tavr program. Is that good or bad? So let's see. With this case, I faced just 3 weeks ago, 100-year-old gentleman, bedridden for the last 7 years because of disabling osteoarthritis. He was admitted with dyspnea and severe right shoulder pain. He was seen by our pulmonary service and they advised for home oxygen. We were consulted because of the findings in echo showed severe calcific aortic valve stenosis, mean gradient of 42 millimeter mercury with preserved systolic function. What should we do with these patients? What we know so far that we should not do Tavr in a patient who have life expectancy less than 1 year or who would not derive a clinical benefit out of it. And it says in the guidelines, it's class 3 indication, Tavr is not recommended at the bottom of the line, table. Tavr is not recommended in patients in whom existing comorbidities would preclude the expected benefit from correction of aortic stenosis. But who are those patients? First of all, we need to know what are the outcomes or the poor outcomes that we should look at, and also we should look to the individual patients what they are looking at. So the patient who is asymptomatic with severe aortic stenosis, they're looking at for improving survival. But the patient who has poor quality of life, they looking for real life. So the poor outcomes, maybe you say mortality, but we can say the fear of death is the most unjustified of all fears. There is no risk of accident in a patient who already dead. So death probably does not make a difference in some patients, but it's a very hard endpoint. There is no difference in death. There is no half death and full death. It's one either die or not. And the other outcome is quality of life. So how can we measure quality of life? New York Heart Association, class 2, is it better than class 3? And class 3, is it enough because it's better than class 4? So we need to have a good explanation of what is the good quality of life. There is in heart failure, the colleagues, they have the Kansas City cardiomyopathy questionnaire, where this questionnaire consists of 23 items with different questions to identify the quality of life. And this correlates very well with the New York Heart Association. So the one is around 80 to 100, and New York Heart Association 2 is 60 to 80, and 3 and 4, so 4 if it is less than 45, this is correlate very well with the class 4 New York Heart Association. And that's why the KCCQ was used as a quality of life measure testing in this examples of how can we define the poor outcome in Tavr. So they take the partner trial and they dissect the definition into 4 definitions. Definition number 1, death or or the KCCQ increased less than 10 points. Patient did not improve. He was class 2 and still remained class 2. He didn't die yet, but is that a good outcome? And they found the death is 19%, poor quality 20%. Then they say, actually, if a patient stayed in class 2 indication, class 2 New York Heart Association, and they did not die, they got the benefit of mortality. Let's redefine it. Say the poor outcome is death and or KCCQ less than 45. And the poor outcome reduced from 20% to 14%. Then they say, third definition, what about those patients who are class 3 indication, New York Heart Association class 2, for example? Then they become class 3, so they got worse. So they consider this poor outcome, and this will not be included in the second definition. Then they redefine this definition to the definition number 3, death or KCCQ less than 45, which is New York Heart Association class 4, or decrement of the functional class more than 10 points. So the poor outcomes increase to 16%. And the definition 4 is making it more complicated, where the patient is either death or KCCQ decrease more than 10 points, or KCCQ less than 45, unless it's increased more than 10 points. So it's very complicated. So there is no much difference compared to the definition number 2. So at the end of the day, the best probably definition is number 3, where there's is either death or KCCQ less than 45, or decrease in functional class defined as the decrement by more than 10 points in KCCQ. So let's see what they found in partner trial. In partner trial, either randomized or they continued the registry. They found the patient who completed that questionnaire at the end at 6 months, 2,100. The poor outcome was 700 people, 400 died. Very poor quality outcome is 260, and worsened quality of life is 44. So then they say, so what are the characteristics of those patients who had poor outcome or had acceptable outcomes? And these variables are a lot. And they would like to come up with a kind of a model that has more clinical usefulness. So they went to something called Harrell backward selection strategy. This strategy is used to select the parsimonious variables to form a final model. They took those multi-variables and they take and all of them, they organize them and rank them according to F value. Then they take the smallest F value variables that contribute to the prediction, and they eliminate it. And sequentially eliminate the alternative process continued until further elimination will lead to loss of more than 5% of the prediction value of the full model. Then they stop. When they stop at these variables. When you look at these variables constitute more than 95% of the prediction value of the full model. When you look at this, you notice the following, that the 6-minute walk test has the strongest factor in predicting the poor or acceptable outcomes. Each additional 10-meter walk being associated with 3% lower risk of poor outcomes. More importantly, higher mean aortic valve gradient, this is very easy to do, is as the higher the mean gradient means that the aortic stenosis is most likely responsible of the problems that the patient has. So each 10 millimeter mercury increase in the mean gradient associated with 18% lower odds of poor outcomes. And at the end, this was calibrated according to the observed outcomes, and it carries excellent calibration. This in partner trial, and also doubled or rechecked in the core valve trial. And in the core valve trial, at 6 months and 1 year, and they found almost 50% of the people, they had poor outcome at 1 year. 50%, unbelievable, I didn't know that. So they did the same Harrell backwards selection strategy, and they found the same thing, the same variables. They have the same, similar power, comparable power. And they added in the core valve, because there's a lot of elderly people, the frailty index in these people, where the frailty index is any 3 out of 4, the slowness, the weakness, unpredicted weight loss, inactivity, and exhaustion. Any 3 out of 5, they fall for the diagnosis of frailty. As you see here, the frailty strongly associated with the poor outcomes, supporting the initial model I talked about. So let's go back to the case. This is a 100-year-old gentleman, bedridden for the last 7 years due to disabling osteoarthritis. He was admitted with dyspnea and severe right shoulder pain. He was seen by pulmonary service and advised for home oxygen. Echo showed mean gradient 42, only barely crossed the severe range. So this patient, actually, we treated him medically, declined from surgery. Another case, 78-year-old lady admitted to the ICU due to severe community-acquired pneumonia, difficulty to wean her from ventilator, and prior to admission, she was ambulating with dyspnea New York Heart Association class 2 or 3. She has severe peripheral vascular disease, severe calcific aortic stenosis, mean gradient was 97. So this patient, actually we did by the balloon aortic valvoplasty initially, and after 1 month transaortic Tavr, and I just saw her a couple of weeks ago. She's doing very fine. The future expectation for Tavr, there are something we call no therapy. We stop, we cannot help, because the treatment that we are giving will not associated with acceptable outcomes. Conclusion, proper patient selection is paramount for successful program. In any one of the program we have, the 19 program we have across the country. Poor outcome can be predicted. We're not 100% sure, but we have a good estimate of risk of those patients. Probably the best thing that we can use is 6-minute walk, or how active is the patient is and how fragile is he. Mean aortic valve gradient, is it very high, more likely to respond to the therapy? If it is the just 40s, probably the other factors play great role. Need for home oxygen, that means that dyspnea might not be improved after the Tavr. Back to the initial poem, that when Alice was questioning, where is the direction, she was asked, where are you going? She said, I don't know. Then it doesn't matter. It doesn't matter what should we choose if we don't know what we expect from any procedure we are doing.